Package insert says everybody needs 16 milligrams. That just is not true. Hello and welcome to this edition of the Wise Medical Minute. In a previous recording, we talked about being treated with Suboxone is not a life's sentence. And part of the reason behind that philosophy is based on a tapering protocol that I developed many years ago that I promised to discuss in greater detail, which is the goal of today's recording. Let's summarize briefly. Everybody talks about Suboxone, but it is one of many brands of a combination of buprenorphine and naloxone. Don't have real strong preferences for which brand, except I don't like the one that's called Mr. Ready. My patients complain, so I'm going to openly mention it to condemn it, because I have to repeat prescriptions too often when it comes substituted as a generic. But all the rest of them, the Bunevel, the Sublocade, the Probufene, and some of the Subutex and non-naloxone containing products can almost, and I emphasize almost, be used interchangeably in certain situations, with the exceptions we'll get to here in a minute. But because of the lack of dosage formulations, the difficulties people encounter in getting off of the buprenorphine containing products is a function of the dosage forms available. Now, in other countries, more so than in this country, the buprenorphine is used as a pain reliever. And people use as low as 25 or 50 micrograms, 75 kind of being a typical dose, 75 micrograms up to 300 micrograms when treating pain in opiate-naive patients, meaning folks who don't take narcotics every day. When they have pain, they get adequate relief from doses in that range. But to put the limitations on the dosage forms available in focus, the lowest dose form in a proprietary product is 2,000 micrograms or 2 milligrams. And that labeling, I don't think, was an accident, making it seem like it was a low dose. But the average doses tend to be in the range of 8, and a package insert says 16 milligrams. That's 16,000 micrograms on a drug that's effective as low as 75 micrograms. So it's a function of the dosages being used that makes it difficult for people to get off. Point one. Second point is, our brain is, I hate this word, but plastic, meaning it's malleable. It can be reprogrammed. I prefer that term. And you can learn to do with less, or it can learn to demand more. But our brain will be happy to have as much stuff that makes it feel good as you will give it, or if it can't get as much, it'll get used to having less. So we take advantage of the fact that the brain is smarter than we realize as we do our dose adjustments downward and tapering people off of the buprenorphine product. And I should emphasize early on here that the purpose of this protocol is to allow people to taper off buprenorphine completely without experiencing withdrawal. Folks who are on these products have already experienced withdrawal from heroin or oxycodone or methadone or morphine or tramadol or whichever opiate they were abusing usually by the time they get to this point. And it's a problem with the drug, not the person, by the time we have gotten them in a need to be prescribed buprenorphine. So these folks will have already experienced unpleasant withdrawal. So now that you have them stabilized, now that they're functional, now that they're able to work, and they're doing everything they need to do as responsible adults, the time comes when you don't want to be tied to a drug every day. So getting off of it is a chore if you fear withdrawal. So the protocol is based on the fact that if we use small adjustments frequently, we can help people to taper off without experiencing withdrawal. Now, the next point in this protocol is buprenorphine is a very long-acting drug. There's no intelligent reason why you have to take it multiple times per day. And tapering is easier if you can transition to once-a-day dosing. So that's another very basic point in this protocol. Now, to emphasize that point a little further, there's a concept in pharmacology known as half-life. Okay, that means when you give a drug, how long is it before half of it's gone from your bloodstream? And the answer to that question for buprenorphine is about 36 hours. So half of that half is gone another 36 hours later. So you still have a quarter of a given dose on board in your bloodstream 72 hours after a given dose. So now the levels may drop below what we would consider therapeutic, somewhere around 24 hours, but you have plenty of drug left on board because of this long half-life, and we exploit that as part of the tapering protocol. But once-a-day dosing, again, is key because a given dose, once that dose is determined, is effective pretty reliably for 24 hours. Now, that same long duration of action we take advantage of by alternating doses when we get a person stable enough to taper. And on an every other day basis, if you change the dose from, say, 4 milligrams to 3 milligrams every other day, the brain is actually seeing 3.5 milligrams a day. So it's easy to tolerate when someone's been stabilized on 4 milligrams, a reduction to 3.5 milligrams. And it's even easier when after a period of days or weeks, you've experienced alternating days, 4 milligrams, 4.5 milligrams, 3 milligrams, 4 milligrams, 3 milligrams. After several days of tolerating 3 milligrams, it's easy to go to 3 milligrams every day. And that reduction in dose is essentially not from 4, but from 3.5. So that concept we use all the way down to 0. The challenges come with the lack of dosage forms available below 2 milligrams. Therefore, when we get people down to the lower doses and they're serious about coming off the buprenorphine, we use a compounded product. And the benefits of the compounded product are we can put whatever amount of medication we want, customize the dose for the specific individual. I use it in the form of troches. These troches are like little gummy bear looking candy things almost. Candy looking things, they're not candy. But the troche comes scored in quarters. And the scoring allows for easy slicing of a quarter of the dose out and taking a whole troche one day and 3/4 of a troche another day. Alternating a whole 3/4, whole 3/4, your brain is seeing 7/8 of a troche. And you put whatever amount that you want in the troches. They're custom made, 30-day supply at a time. And if you follow the Locke protocol, a 30-day supply almost always will last at least 5 weeks. Now, that's during the tapering phase if a person is, motivated and truly ready to get off. Now, the other basic point I have to make before we leave this subject is stabilizing people initially, if the goal is to get off drugs completely, needs to be done with as low a dose as possible up front. And to that end, I say ignore the stupid package insert. Package insert says everybody needs 16 milligrams. That just is not true. Basically, I've seen people quite stable on as little as half of a 2 milligram dose. I've seen people quite stable on 4 milligrams, probably almost a majority of the time. 8 milligrams is plenty for almost anybody. 16 is just too much, and when people have to have 3 times 8, 24 milligrams a day, they're probably selling it or sharing it with somebody or doing something else in the way of diversion. It's just not necessary. So the key to successfully tapering off of this stuff is stabilizing your dose as low as possible to begin with. Another key to success of this protocol is not tapering before people are truly stable. We don't want people going through a divorce. We don't want them about to lose their job. We don't want them on a new job. We don't want things at home not to be copacetic. We want life's circumstances that lead to recidivism to not be an issue to interrupt the tapering. So that's where the counseling comes in, talk therapy. A lot of times just getting to know the person well, which we spend a lot of energy doing. All those things are more important than the dose of the drug. And when those things are all ideal and everything's like it ought to be, inevitably that tapering effort will be more successful. So that's a quick summary of the Locke protocol for tapering off of buprenorphine. If you have similar questions or other questions related to this or other topics, I invite you to send me an email at info@wisemedicalcenter.com, and we'll include your question in a future recording. Thank you for your attention, and I thank you for listening to the Wise Medical Minute.
Thank you for listening to the Wise Medical Minute with Dr. Thomas Locke. Dr. Locke addresses current events as well as important medical issues using responsible, unbiased journalism approached from a medical perspective. We invite you to submit questions or comments or suggestions for future topics by email to info@wisemedicalcenter.com. Again, thank you for viewing the Wise Medical Minute.